Cause I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission, I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain, keep on working, open curtains. Haters swerving cause they ain't ready for your final version. I'm never gonna give up, fall down, I just gotta get up, yeah. Cause this is my road.
You're listening to the Tom Ficklin Show on WNHH-LP 103.5 FM, your home for community radio.
Good morning, everybody. It's really a pleasure to kind of it's a pleasure to be up and awake and on my right mind. I'm not trying to be religious. This is not a religious or a spiritual show, but in some ways, the Tom Ficklin Show, through the graces of WNHH 103.5 FM, we've been blessed, and I use that term even in a secular sense, blessed to kind of be on the air for over 5 years, and now to even be broadcasting not only on Monday mornings at 11 a.m., but also on Fridays at 11 a.m. Thanks to Harry and Paul kind of giving me this additional day in the week. Today is an important show. I mean, every show that I do is important, but we're going to talk about the overdose crisis. Actually, is there an overdose crisis, and the communities of color and the impact of substance abuse, et cetera. We're really I would say grace to have Dr. DeLaw, who's the Community Services Administrator for the City of New Haven, here with us, and Christine Acasio has been kind enough to kind of arrange for the three of us to kind of come together. We have about 55 minutes, so Dr. DeLaw and Christine, we don't have to kind of rush. We can really just unpack some of these issues, and again, we want to talk about generally data and the disparities pertaining to overdose and substance abuse, and reasons for perhaps the disparities, stigma even, something called the bigger picture, because there's so many ramifications. I was thinking, Dr. DeLaw and Christine, about the bigger picture. My mind went to the opium wars back in like the 1850s, 1860s, in terms of China and Britain, and just the merchandising of opium and how it became a transatlantic kind of product. Also, the city's responses to get the crisis in general, but particularly in terms of substance abuse. We've heard about some things in the past, but this issue is going to be with us forever. So this is not a retrospective conversation. It's really a prospective conversation. And in that vein, we're going to talk about resources that Dr. DeLaw and the Community Services Administration for the city can provide, and how you, the citizen, I mean, everybody in New Haven, we need to we can come together. We can any problems we have, they need to be solved collectively, not from a policy, not from an administrative standpoint, but from a collective standpoint. So let's jump in, and Dr. DeLaw, welcome. Good morning.
Good morning, Tom. It's great to be here. Thanks for having us on.
And Christine, good morning. How are you doing?
Hello, good morning. I'm doing well, thank you.
Good. So Dr. DeLaw, let's jump in. I mean, talk to me. This is again, we have about 50 minutes now to really unpack some of these issues. I might toward the end of the show ask you to kind of go through the litany of the various services that you and departments that you supervise. But let's just focus right now on, because that's a list of 10 or 12 or 13. But let's just focus right now on the substance abuse issue and the overdose issue. So share with us how you'd like to begin.
Yeah, I think it's probably worth starting by sharing some of the data that we have. It just sets the framework for the rest of the conversation. The opioid crisis has been called the opioid crisis long before this year, or even before COVID. So in general, what we're seeing here is really the continuing rise of opioid-related issues, deaths and overdoses. During the pandemic, that was a trend that was happening before the pandemic. I think it interacts with the pandemic in very important ways. The fact that services shut down. But what we're seeing right now, just to share some figures with you. So in 2020, with respect to fatalities, there was a 15% rise as compared to 2019. We have so far in 2021 in the state of Connecticut, 121 confirmed opioid fatalities. And New Haven County has the highest mortality rate in Connecticut. Now, it'd be great to get down to New Haven, as a town, but we just don't have that level of analysis yet. So we look at the statewide and countywide trends to inform us. Anecdotally, I think we're seeing that here. We're certainly seeing a rise in the number of times that our EMS gets called out to scenarios where there's an overdose involved. And those scenarios don't necessarily result in a fatality. They're often reversed on the scene with Narcan and naloxone. And I'm hoping Christine can talk a little bit more about that.
Okay.
It's such an important aspect of our response here. But it does give us a window into understanding the scale of the problem. We have to look at different data sources. We look at our EMS data, we look at data coming out of our emergency room, and ultimately we look at data that is provided to us by the Office of the Medical Examiner when the causes of deaths are determined. Let me just, I know we were going to, hopefully focus on the New Haven population and communities of color in specific, because this has been an interesting dynamic in terms of the conversation.
Sure.
Hopefully we'll get a chance to talk a little bit, explore that piece a little bit further. I love your historical reference too, because there's so much to unpack in there. The increase among African Americans is 64% between 2019 and 2020. So in that trend of 15%, the largest increase is among African Americans. 40% increase in Latinx. The death rate among Blacks eclipses the rate among whites now. So when you look at actual, percentages, it's much higher. So we have a history in this country, and we can get into that a little bit, but that's not my expertise. But the way the opioid crisis was addressed when it was primarily seen as affecting the majority community is unfortunately different from how we, sometimes look at it now. I'm hoping that the past isn't, kind of a predictive element of the future, and we're hoping to do things differently. But that's just some data that I have to share with you, and that we can get into, the reasons for this is happening. And it seems like Christine somehow got kicked off, and I'd love to have her dive in here, or we can continue as the show must go on.
Yeah, I'm sure she'll come. We'll keep hope alive, right? I was a little hesitant when Christine chatted with me about using the word crisis, but from what I understand, and I don't mean to be pedantic or redundant, but it is truly a crisis from your perspective, from a data standpoint.
Yeah, so we have to look beyond, of course, it's tragic when people succumb to overdoses, and we can talk a little bit more why that is. But it really is, that's the tip of the iceberg. For every death that makes the newspapers, and these are tragic deaths, there are dozens of overdose events, maybe even more than dozens, because some of them don't come to our attention because EMS is not notified. And, so I think the scale of the problem might be even larger than we imagine.
And Christine, Dr. DeLisle has kind of mentioned your name 2 or 3 times, so I imagine we should be respectful and allow you to speak. I mean, women are no longer in the kitchen. I know that's a bad thing to say, but hey, we all get our trying. But so share. Dr. DeLisle has invited you to kind of comment somewhat.
Sure. I would agree that this is, we're using a lot of these superlatives lately, especially with COVID, but this is an unprecedented crisis nationally. We saw 88,000 deaths, and there has never been this sort of overdose crisis in our country, in the history of our country. I do think that it's important that we look at disparities. It's incredibly important that our data is able to be disaggregated so that we can look at race and gender and these sorts of things. There are some potential reasons behind why the overdose crisis may be hitting communities of color particularly hard. But I think it's important to acknowledge that in many communities of color, particularly Black communities, there has been an overdose crisis since heroin, right, sort of hit the scene in the 60s and 70s, and differential access to healthcare, to substance use treatment, to harm reduction services has really exacerbated this crisis in the current moment. I would say that, some of the reasons that we've seen potentially influence the rates among people of color are that, white folks tend to be more likely to inject, right? And so this has provided a little bit of a protective factor for folks of color who may be using their drugs in a different way. Injection drug use puts you at very high risk for overdose. And unfortunately, what we've seen since about 2014, 2015 is a new synthetic, not new, we've been using it in the medical field since the 70s, but fentanyl has started to contaminate the drug supply essentially. And so people who were not used to necessarily needing to think about overdose prevention now need to be thinking about overdose prevention. So non-opioid users, people who don't inject their drugs, there is a new reality right now putting folks at risk if they're using sort of any type of street drug.
Dr. Delau, any comments about that in terms of reasons for the disparities? I mean, what Christine has mentioned is really that list. In a way, I mean, I'm a heavy content consumer. I don't want to. It's a bad word to use addict on this particular show, but I'm certainly a digital addict. And just to hear Christine mention the litany of reasons, it just, you hear them before, but just to really take them in and digest it. I just wondered if you wanted to elaborate any more on the reasons for the disparities.
Yeah, I mean, I think some of it, again, going back to the history part of it, and there's still a sort of a common misconception, the kind of the origin of the opioid crisis, at least the way the narrative has been told, is that it started with prescription drug misuse. And although that there was an element, to that for sure, with the opioid manufacturers and distributors promoting widely in the medical community. And in fact, I trained at a time that was just beginning about 20 years ago, where we had initiatives such as, pain is the fifth vital sign. Now you look back on it, you know where that came from. But at the time, it was sort of the lexicon of the medical community. So when the medical community started to realize there was a crisis, it happened in a bit of a different way, depending on whether you're white or Black or Latinx, because there has been historical undertreatment in the Black and Latinx community of pain. So it's a very interesting dynamic as to how this started, and now fast forward 15 years or so, or 20 years from now, since when I trained back in New York City in the early 2000s, we have a different dynamic and we have these disparities. So we're faced, as Christine mentioned, with something new.
And we're going to move to not just describe the past, but we're going to talk about some of the proactive efforts and resources available. But before we do that, I just wondered, Christine and Dr. Delau, if you might want to, we hear this word stigma a lot, and people being characterized, and I won't say blackballed, but let's just say characterized in a negative fashion. Any comments about this apparition of stigma?
Yeah, I appreciate you raising that. I do feel like it's good to spend a little bit of time on stigma. So stigma is when we label somebody and kind of imply there's a characterological or moral flaw in that individual. And this is on a pragmatic level, this is a substantial barrier for folks getting help. Like that's where it boils down to. 25% of folks who would otherwise seek treatment say the primary reason they don't seek treatment is because of stigma. What their neighbors will think, what their faith leaders will think, what unfortunately what the medical establishment will think of them. So we're losing 25% of people who we could get into treatment, which are again science-based interventions to treat the disorder. And then we can't talk about stigma without talking about language. So what is stigma doing? Stigma and the language that's used to perpetuate stigma is doing work. The work it's doing is, number one, it's separating people, saying, you know, as bad as it for me, at least I'm not like that, right?
Mm.
I'm not an addict. I'm not a junkie. So that's the work it's doing. And then, you know, any middle school bully can tell you that, or a recipient of that can tell you that that's part of it, separating people. And the second piece it's doing, it is diminishing people. So there's differentiation and diminishment. So again, if you're at the tail end and receiving end of the separation and diminishment, and there's no doubt that, you know, people of color and communities of color know this, you know, instinctively,
Mm.
you're not going to be as engaged in the system. You're going to have reluctance to participate in treatment. You're going to have reluctance to participate, and that's just completely counterproductive. We need to kind of move across and transcend this, you know, this work. And it's going to take a lot of work. Again,
Yeah.
I know you want to look forward, but I hearken back to when I was training. When I was training as a primary care doctor, we were just starting to make this transition. We were saying, okay, yeah, let's use person-centered language. Let's not say drug abuser. Let's say, you know, people with substance use disorder. So you're not defining people by a certain
Yes.
type of behavior. And, you know, as a treatment provider, as a former treatment provider, you know, in terms of primary care, not in terms of substance use
Yes.
necessarily, the most important, you know, aspect of this in an treatment encounter is I need open and candid dialogue from the person that I'm trying to help.
Mm-hmm.
And even if they overhear in the waiting room that, hey, you know, the junkie's next, you know, make sure you got 30 minutes all on calendar, that's it. That ruined that encounter, because now that person is not going to be open to sharing information with me. Christine, I don't know if you want to jump in here. Sorry.
No,
This is so important. Please, Christine.
absolutely. I think, you know, all of what Dr. Dalal is saying is absolutely right on. And in my experience, stigma can be the single most difficult barrier to overcome. I think, you know, the war on drugs has been insidious in the ways that it has promoted misinformation about drugs, damaging stereotypes about people who use them. And as most, you know, we're seeing some movement in different parts of the country, but as most drug use continues to be criminalized, so are the people who use them. And that criminalization really makes it very difficult to undo a lot of the stigmatizing attitudes that people hold. And really, you know, what we're looking at is very complex. It's about trauma. It's about you know, ACEs, or adverse childhood experiences. More than anything, I find that, you know, when folks are really struggling with substance use, there's a root there in pain, and not just physical pain and emotional pain. And whether that is, you know, experiences of poverty, incarceration, homelessness, or a traumatic event that's happened in someone's past, you know, what we're really looking at is a sort of, I don't know, like a biopsychosocial phenomenon that can't be boiled down to simply moral failing, or you don't have the willpower. These are things that I don't believe. I believe it's very complex, and that people are seeking relief from a great deal of pain.
Excellent. Because, you know, just again, you're listening to the Tom Ficklin Show, and really had the pleasure this morning. And by the way, Christine and Dr. Dalal, the shows are archived, so folks, the one thing they do, it does live beyond this immediate moment.
Wonderful.
And so folks often share the links, and because I think if someone views this show even a year from now, they'll still find it relevant and intuitive, and even maybe even inspiring. Before we get to kind of what we might call the bigger picture and the city response and even resources, I guess I want to ask you, Christine and Dr. Dalal, and this came to me when you were talking about availability in a way with the medical marijuana legalization. I'm sure you have some comments or thoughts about how that trend might impact people's behavior.
Yeah, I can start, and then Christine can jump in. I think the legalization conversation again is it's been a complicated one, and you know, part of this lens that we hope to put on legalization is a racial equity lens. Um, you know, this spans from you know, how, you know, businesses will be brought to bear, and who will be calling the shots with those businesses and where they're coming from, and it also deals with the expungement of records of folks
Yes.
who we know. And I think the way it intersects with the opioid crisis is really, I think it really starts this conversation about why are certain things criminalized and what impact that criminalization has. So that's, you know, the direct link in my mind about with cannabis legalization, with this, you know, issue that we're talking about today.
Christine?
Yeah, I think there's a lot of promise. Speaking to racial equity, you know, an enormous amount of revenue can be created through these regulatory, legal regulatory schemes that can be reinvested in communities that have been impacted by the war on drugs. And we have seen some data now that there have been a few states that opened access a few years ago, that even, you know, even medical cannabis laws are associated with, you know, a significantly lower state level over opioid overdose mortality rate. So, you know, this is giving patients another option to manage their pain, to manage different pain in different ways, to manage other health conditions where they may not need to rely on opioid medication. And so I think, you know, the more patient choice, the more individual choice that we have in being able to access what we need safely, the benefits of a legal legality is that you can purchase what you're going to consume and you know what's in it. And that is something that most folks buying street drugs do not have the privilege of being an informed consumer of their products. And so I think that there are a lot of ways that this could benefit both the overdose crisis and you know, the population of Connecticut broadly.
Excellent. I was intrigued, Christine, when we chatted a little bit through the exchange of emails prior, and you referenced the term big picture, and I love that. I love that because I think folks sometimes are challenged with looking at the micro versus the macro and what's in between, and even locating themselves on that big picture. So, Dr. DeLaw and Christine, comment if you would about the bigger picture in the context of this conversation this morning.
Sure, I'll start with that. When we think about, well, at least when I think about big picture, I think about what are the policy approaches on the table. So again, for the way I interpret kind of big picture versus micro is that micro is, you know, the interactions that we can do on a day-to-day, individual by individual basis, or even a program by program basis. But big picture to me thinks about what can we, and you actually referenced earlier, is what can we do collectively? I know, you know, we use the term policy as often, but policy can sometimes seem a little distant because then it's like, oh, well, you know, what law are you going to pass to help us? But it's really more about what we can do collectively and what are the set of, you know, policies, laws, you know, infrastructure that can support a more humane and evidence-based approach to this. Mm-hmm. And as you know, those types of principles apply across different public health issues. So, you know, it's when we talk about building infrastructure for the opioid crisis, we're in parallel talking about the type of infrastructure that we need for a strong public health system, which means that if should we ever get hit with another, you know, a COVID-like epidemic, we want resilient systems, not just at the governmental level, but across society to help us handle those. It means, you know, dealing with mental illness in a systemic way. And understanding what are the policy approaches and the systems approaches that support that. So again, that sounds lofty, so let me offer an example. A policy approach, in terms of opioid use, is the liberalization of providers that can offer opioid use treatment. And Christine can talk more in detail about this. At the federal level, there was some regulatory work going on to allow providers to provide, evidence-based medications for opioid use disorders by reducing the barriers to participation. So that's something that can be implemented nationwide is a policy approach and will help move the needle on the bigger picture. And Christine knows a little bit more about that, so I'll pass it to her.
Sure. What Dr. Dalal is referencing is particularly prescribing buprenorphine, which is one of the gold standard medications for opioid use disorder. There is an additional training and a waiver that people need to get even after they've already been waivered to prescribe controlled substances by the DEA. And, what we hear from providers is that, there is so little time in their schedules that they receive training in other ways, that they're getting training because they're already DEA waivered for other substances. And buprenorphine is a medication that can move into primary care. This is a medication that can be prescribed out of the office, that folks can take to help stabilize basically their lives, and a lot of wonderful outcomes come from medication for opioid use disorder. And so moving away from additional barriers for folks who are already well-trained, capable, equipped, and interested and ready to do this prescribing is incredibly important. I think investment in harm reduction and removing the stigma around harm reduction interventions is incredibly important piece of this big picture puzzle. Harm reduction, references a sort of set of interventions that we use, but it really is also a social justice movement. It's a broader philosophy that dictates how we should approach serving people who use drugs. And that is to say, with respect, with dignity, with compassion, and with humanity. And I don't think you can really go wrong leaning on some of these values. And those are the values that underpin harm reduction. And because in my eyes, the key intervention in harm reduction is relationship building. It's building relationships of trust. It's building relationships back to systems that have been harmful, if not violent, in the past. These relationships allow for an enormous amount of change to be made. And we would be surprised, I think, to see some of the change that happens on its own when you provide people space and respect and options. And so harm reduction is certainly not meant to replace treatment, not meant to replace any of these other approaches, but it is an important piece to that puzzle. In my eyes, of the bigger picture, both at a policy level, reducing the harm of criminalization of policies that really create a lot of barriers to care and wellness for people who use drugs, but also at an individual level. There's a lot of potential that we see realized when we allow folks a little more time and a little more space to make that change on their own.
Christine and Dr. Dalal, when Christine was chatting, one of the beauties of being the host of the show, some hosts want to pretend that they know everything. I'm not that sort of host. So my mind went back to just the data and disparities that you mentioned, because I believe you're saying, and correct me if I'm wrong, that even if no one became addicted from today on, there still is a substantial amount of people that are suffering from this behavior. So for folks that are listening, I think one of the purposes of the show is to show that there's a not necessarily a metaphorical lifeline, but a specific way of helping people get become whole, become healed. I mean, and it's not just and so there's a significant number of folks that are dealing with this issue. Is that correct?
Yeah, absolutely, that's correct. And
Mhm.
I'd love to just pick up on, Christine said it so well, but I'd like to pick up on this, this idea of options.
Yes.
Um, because in reality, people who use drugs, each individual is on a specific point, whether our metaphor is a journey or a cycle, whatever we want to call it. There are some individuals who are, at a point where they are heavy and destructive use. The set of options that is going to work for them is very different from someone who's been in recovery for 10 years. So again, going back to this big picture conversation, we have to be prepared collectively to think about a range of options, because that is what's going to work for folks. And it's not just a cookie cutter one, this worked here, so we're just going to kind of apply it across the board. Anytime something that involves relationship building, respect and dignity means respecting what the other people's, others' preferences and needs are. And, it's impossible to apply a cookie cutter approach to there. And especially now that we're seeing this crisis impact communities of color more, we have to be sensitive to how these programs are implemented and making sure that they're implemented in the ways that are appropriate and make sense.
Mhm.
So Dr. Dalal, let's just jump into because you've referenced it away, but we can spend a good, 8, 9, 10 minutes if we need to on the city's response. I mean, you kind of indicated a little bit, but I think our viewers and listeners might be interested in more detail about the city's response. Not that you have a magic wand, but I know you're still trying to manufacture one, and you're looking at AI, and you're looking at robotics, and you're looking at, I don't know what else, what you're looking at, praying, but what's I mean, I know that you're a human being, but you're a super person. I'm sure Christine agrees. But what is the city's this current city's response, and some of the, even prospectively, how you might want to see the city, not only just New Haven, just municipalities throughout the United States, but particularly in terms of New Haven here. What's our response?
Yeah, I appreciate that, but I disavow the superhuman label.
I've looked at your background, so I guess that's.
Mhm.
But anyway,
So I'll go on the record. But
Right.
yeah, no, I think we have to look at this in a sense that we have to find out what we're doing, what other cities are doing. We have to collaborate, learn from each other. So it's not just about New Haven. There's so many, cities across the United States and globally, for that matter.
Yes.
We always forget that we live in a global community.
Yes.
And we've had great examples, just to the border, the north of us, of interventions that have proven successful. And but sometimes there's a little bit of a narrow-mindedness there, if I may, with respect to looking across our borders for interventions. But with respect to New Haven, just a little bit of kind of recent history is that as most listeners will be aware, if they were in New Haven a few years ago, there was a substantial overdose event on the Green, which primarily ended up involving K2, although there was some question about how much opioid was involved, because many of those folks who overdosed on a quote unquote bad batch of K2 were already on some sort of opioid substance, whether it's through opioid medication treatment or co-using with the K2. And so there was some confusion about that. So, but anyway, the genesis was that there was a task force appointed immediately in the aftermath of that to look at both K2 and opioid. The K2, issue subsided, at least in terms of, the bad batch issue with, resulting in individuals needing to go get medical attention, but the opioid issue remained. So that became the focus of the group. So that was the genesis of the opioid group. And then of course we had the mayoral transition, and I was tasked with reviving it and rethinking it and understanding what it could do. And luckily, at the same time, there were national organizations, a group called Vital Strategies, which actually Christine works for, but has been detailed to the city of New Haven for full time to help us with this, that was interested in working with cities to develop comprehensive and progressive approaches to the opioid crisis. And it's under that framework that our New Haven Harm Reduction Task Force, it was rebranded as Harm Reduction, not Opioid Overdose Task Force, has reconvened. Christine is the facilitator of that task force, so I can pitch it to her to talk a little bit about the composition and number of people involved with that.
Sure.
It's on you, Christine. You've hit a few. You've already hit a few, several home runs and triples, but you know you're an athlete, so go for it.
Once upon a time. Yes, we've reconvened the Harm Reduction Task Force, which is really exciting. There are approximately almost 80 folks on our listserv, and we held an open monthly meeting every fourth Friday. We have about 35 different organizations represented there across stakeholder interests, whether they are service providers, harm reduction service providers, treatment providers, city officials, folks from fire, from EMS, from police, from HIDA. We have just a really wonderful group, I think, of folks who are invested in the health and well-being of people who use drugs. And so we're trying to collectively figure out what New Haven needs, what folks who use drugs want, and trying to collaboratively make those things happen. And so, you know, one example of this is really using our data to target street level outreach, because this is one of the most efficient and effective ways to get naloxone to people who use drugs.
Now, just for someone that's listening, naloxone is
yes, exactly. Naloxone is something of a miracle drug. It reverses an opioid overdose, and so it is important to know that the situation that we're in is made even more tragic by the fact that every single opioid overdose is preventable. Fatality rather, every death is preventable. Naloxone will reverse this overdose. It essentially kicks the opioids off your brain receptors and sits there in its place. So you can come out, and it's a wonder actually to see this happen. It looks truly like a miracle. And it is otherwise very, very safe. I could inject myself with naloxone right now and nothing would happen because I'm not using any opioids, right? And so very safe, very easy to use. I think the youngest person I saw trained on how to use naloxone was 6. And she got it, and very, very simple administration, right? So we really want to get as much naloxone as possible into the hands of people who use drugs, their peers, their loved ones, their neighbors, anyone who might come into contact, right? Thinking of it as a part of your first aid kit, essentially. So these are the sorts of things that we're trying to think about in the task force.
And yeah, Christine, go ahead, Dr. DeLaw.
Oh, I was going to jump in with an example of what we're doing. I know, so very much related to what Christine had just mentioned. Our New Haven Health Department is collaborating with the Quinnipiac Valley Health Department on a grant we received from the state called Overdose to Action, which means overdose data to action. So using data to move the needle. One very important program that we trying to be very proactive about is ensuring that places of businesses, especially restaurants, given of course what happened a month ago at Jack's Steakhouse, have the opportunity to be trained on naloxone. So it's an open training, and it's almost like happens in a pop-up model where, you know, our team will show up at a restaurant at request, work with the manager, owner of the restaurant, the staff of the restaurant, do the training as Christine mentioned. Again, it's pretty straightforward since the administration is relatively easy. And provide them and leave, naloxone with them. And they leave as part of the training. And this,
So people should call the public health our city health department.
Yeah, absolutely. Yeah, we'll share some numbers as well with respect to this resource as well as the others. But I can send that to you separately since I don't have it right in front of me.
And that relates, we hear in terms of the harm reduction, that people are sometimes people we can't forget, some people are caught up right now. We need to go to them. So I mean, that's really fascinating. By the way, and you mentioned a particular restaurant, and certainly there are others, and so let the record show we're not necessarily stigmatizing a particular restaurant here that happens to be in New Haven. Could have happened anywhere and probably is happening other places. So Dr. DeLaw, before we have about 10 or so minutes, and so before I get into the asking you more about resources, I just wanted to ask you a softball question. When people will hear about the Community Services Administration and the Community Services Administrator, some folks will know what that means. Some folks will not know what it means. Other people will think, why is it even necessary? But list, I mean, there's 10, 15 departments, areas of focus. I mean, you get paid, 10, 15 different checks? I'm just trying to get a handle on your responsibilities. But
if I do get 10 or 15 checks, they haven't showed up in the mail yet.
It's in the mail. It's in the mail. It's in the mail. It's in the mail. It's in the pilot legislation.
Yeah, we have been consumed with budget discussions lately, but we won't burden this discussion with that. Yeah, so thank you for asking. I know it is a broad number of programs. So the Community Services Administration is one of the mayor's cabinet level, kind of operational units, along with the CAO and Economic Development Administration. The programs that fall under Community Services Administration are pretty large. It includes health, which has been obviously extremely active over the past year. But it also includes the Office of Homelessness Services, includes our Food Systems and Policy Division, includes our Youth and Recreation Department, it includes our Elderly Services Department, and includes our Special Projects unit, which oversees reentry work and the launch of our mobile crisis team, as well as some other special projects as well. So it's not 10 or 15, but within each of those programs that I mentioned, there may be anywhere between a dozen, half a dozen to 2 dozen different programs, even within each of those departments.
And just as you were talking, Dr. DeLaw, I mean, correct me if I'm wrong, but everybody that's received there's a certain percentage of folks that are receiving services through directly or indirectly those departments that you mentioned that might know of someone or dealing with a substance abuse issue.
Yeah, we try to be very collaborative in terms of identifying opportunities for collaboration with the population we're trying to serve. So I give you one example. We just launched a reentry center in collaboration with Project More, and it's really a long time in the coming. It's a place where folks who are returning from incarceration have a place to be dropped off, and literally having wraparound services available at the location they're dropped off. 80% of folks who are returning have a history of substance use disorder. So again, Christine, along with, I have to give a shout out to Carlos Sosa Lombardo, who's our special projects director and overseeing this initiative. They've worked out a system where harm reduction supplies and materials and services would be available on site for folks who are returning.
Good. See. Excellent. And even when you mentioned elderly services, and some of my friends received the weekly food delivery, and sometimes flyers are attached to the food boxes, and so there's just so many ways of reaching people that I think we can just continue to maximize. And I was really glad, Christine, when you reached out to me for us to do this show. Christine, locate us a little bit. You referenced before we went on air that you're not necessarily an indentured servant to the city, and you're not necessarily a slave as well, but you're on assignment, as Dr. DeLaw has mentioned. But how did you find your way to this lovely city called New Haven, Connecticut?
Well, Vital Strategies, like Dr. DeLaw said, has a partnership with the city that provides for my position currently. I was doing some consulting work and looking to get back into a full-time job with actual colleagues and where I could feel like part of a bigger whole. And I came across the posting and was very gratified to hear they were open to remote candidates given COVID. And so I, in October, joined Detailed Out to the Community Services Administration, joined that team, and it's been just a really wonderful, warm welcome. And I'm very glad to be of service to the city of New Haven.
And has Dr. Dalal renewed your contract, or has he bought you off to stay for another 2 or 3 years?
I think that's out of both of our hands, but fingers crossed they'll reinvest.
You referenced the umbrella type meetings where various providers come together. I assume that's been taking place via Zoom?
Yes, it has.
And is it open to the public, or I'm just curious, there could be people that might not represent a particular organization that might have an interest in sharing or participating or learning more about it?
Sure, it's semi-open. We don't post the link publicly, but anyone is welcome to email me to get on our listserv. It would be wonderful to have folks with lived experience, parents, folks from community are welcome. We just don't sort of put it out there for anyone to join, but anyone is welcome to join. Just get in contact with me. I can share my email address with y'all, and I'd be very happy to talk to anyone who's interested in moving this work forward.
And I mentioned that because it's my sense. Some days, of course, I guess like everybody else, you get up optimistic. Some days you get up pessimistic. But this morning, I'm trending a little more optimistic, and I think folks are realizing that if we're going to get out of this COVID-19, there might be a COVID-20, COVID-23, COVID-24. We may be into for the long haul, but I think folks are realizing that they can join up. They can boot up. They can kind of join this movement for health and safety. We have about 7 more minutes, so let's kind of freelance, if we could, Dr. Dalal and Christine, about what might be on your mind as we kind of conclude. And it could be either in terms of resources, or just asking for a pilot to be approved, or asking for Yale to give more money, or just, it could be anything that might be on your mind. But or you could just keep it under the focus of the topic for the show. Dr. Dalal, I'll start.
Sure, I'll take up the challenge for the first question, and then I'll turn it to Christine to talk about resources. I think that's going to be very important, pragmatic information.
Okay.
What's on my mind right now is that we're in a moment of opportunity. And the reason I say that is, not just because I feel like I'm optimistic, but I've reason to be optimistic because of what's happening at the federal level. Mm-hmm. We have a massive investment for the first time in probably a generation, maybe even a generation and a half, of resources coming into municipalities, either directly through the American Rescue Plan aid to municipalities, or indirectly that'll work its way to our city in some way or form through various administrations, whether it's the state or whether through a federal agency. So, I'm sort of thinking that this is an opportunity to do some important work that really accelerates us in the direction that we've been talking about this, during this program, to work on some of those bigger picture issues, and to work on some of those, community and collective issues as well related to stigma, and setting up infrastructure to help us do that.
Christine?
Yes, I can pivot to resources. There are a few that we'd like to share. I'm very happy to share this over email if you want to do this with your social media. But you can find information about the harm reduction work at the City of New Haven at harmreduction.newhavenct.gov. My email is there if folks are interested in the task force or have other questions and would like to reach out. I welcome that, please do. Our partners at the Quinnipiac Valley Health Department have their own website for connecting folks with resources, connectgnh.org. And I really want to shout out our wonderful syringe service providers in the city, the community healthcare van run out of Yale, as well as SWAN, Sex Workers and Allies Network, who are doing phenomenal harm reduction work. If you know someone who could use sterile supplies or an ear to speak to, connection to other kind of healthcare, there are wonderful, wonderful resources. And then, at the national level, SAMHSA has a national helpline that is always open that can try and help folks connect to services at 800-662-HELP, which is 4357. And of course, our local 211 number is an important resource for folks who are looking to connect with housing, to connect with whatever sort of social need is arising in their lives.
Absolutely, so key. Dr. Dalla, I want to kind of, as we conclude, as you can see, sometimes I take a levity approach to these matters. You're working at the pleasure of the mayor, correct?
Indeed, I am. I'm an appointed position.
So talk about that. I mean, people are sometimes intimidated by getting involved with public service, knowing that you're subject to political whims, political elections, and you've had a successful career prior to jumping into this these challenges. What was the incentive for you? Young people. A lot of young people will watch and view the program, and they're always looking for career advice and just how people have navigated their trajectory. But what was the attraction to you to get involved with something like this, where you have to work at the pleasure of politics?
Yeah, that's such an interesting question, and it's something I've been navigating for a while. So I mentioned that I trained as a primary care doc and even practiced for a little while, but I was always interested. We're back to the term bigger picture. I had this nagging sense that, once the patient walked through my door, it was already too late. There was something that should have been done before.
So the social determinants of health thing that we hear so much.
I didn't call it back then, but I had this sense that I needed to focus on something bigger picture. So I always, from a career standpoint, knew I was interested in policy approaches, systems approaches. So pretty soon after I finished my training, I kind of got additionally trained in health policy and landed a job in public health at the New York City Department of Public Health, which is a large public health department. Yes. And a very innovative one. And that set me off on my public service career. I spent 7 years at the Connecticut Department of Public Health, overseeing their chronic disease prevention programs, and learned to navigate, as you mentioned, sort of the political issues, but it wasn't an appointed position at the time. And then, like Christine, I spent some time consulting as well, and I got the call from our now Mayor Elliker asking if I'd be willing to help out. Initially, I paused because it was outside of my expertise. But when I thought about it in a big picture way, I really see it as an opportunity to apply what I've learned in policy and science and medicine to try to address the root causes of issues, where we can work on preventive approaches rather than remediative approaches, not just in health, but across the board. And that's why I'm pretty passionate about the public service aspect of this. And the politics, I see that as conversation. These are interesting conversations to have. It's all about relationships and having good conversations.
No, I appreciate your sharing that detail. You also spent some time, correct me if I'm wrong, at the Fairhaven Community Health Center.
Yeah, that was one of the places where I practiced primary care. Not as long as I'd like to, because I was kind of going between gigs. But I think that really helped ground me in some of the issues that New Haveners face.
Excellent. Christine, kind of the same question to you, and share, if you will, about Bloomberg Philanthropies, because I'm really intrigued for people to see that we're not working in isolations. Philanthropy, academics, politics, economy, DC, there's an interconnection between all of this.
Yes, Bloomberg Philanthropies is the funder of the grants that the overdose prevention program at Vital Strategies is funded by. And they are working in Michigan, in Pennsylvania, in New Jersey, as well as New Haven, Connecticut currently. And so they have been very generous in funding this overdose prevention work at Vital Strategies here in the United States. And we're really excited to see all of the progress and new programs that might come of it and these sorts of things, including in New Haven. In terms of how I found my work, I always wanted to serve community in some way or another. That I was raised with service really at the forefront of our values. And when I met harm reduction in, I want to say 2007, it just clicked. And it felt like the way I wanted to show up in the world for other people. And it gave me new language to understand drug use and these issues. And it was that was it from there.
Speaking of that, is it Harry's going to play the station manager momentarily, so we'll know that'll be our cue that we will no one will be able to hear us. But I always push you may have sensed it sometimes I'm the guy that likes to push the envelope. So I'm going to push the envelope until he plays the music. But that'll be like probably in 30 seconds. But any parting comments? I just want to thank both of you for being in touch, and we hope to kind of continue this conversation. Dr. DeLaw, I mean, we have any of your departments, I'd love to kind of chat with them at another point if it seems appropriate.
I would be more than happy. I would say the parting comment is let's treat each other with dignity and compassion and grounded in science.
Excellent.
As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the
This is Harry Drove, and you're listening to WNHHLP 103.5 FM New Haven.
And I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. I'm never gonna give up, fall down, I just gotta get up, yeah. Cause this is my